Welcome. Today we're shedding light on a serious heart condition that can affect women during and after pregnancy: peripartum cardiomyopathy, or PPCM. The exact cause of PPCM remains a mystery, but research suggests a combination of factors may be at play. These include hormonal changes during pregnancy, genetic predispositions, inflammation, pre-existing cardiovascular conditions, nutritional deficiencies, and even viral infections. Essentially, it's likely a perfect storm of stressors that overwhelms a susceptible heart. At its core, PPCM involves a weakening of the heart muscle, specifically the left ventricle, which is responsible for pumping oxygen-rich blood to the body. This weakening, known as dilated cardiomyopathy, leads to reduced cardiac output. The heart struggles to effectively pump blood, causing a cascade of problems like fluid buildup in the lungs and other organs. The heart chambers enlarge and become less efficient, further compounding the issue. PPCM is a relatively rare condition, affecting approximately 1 in 2,000 to 4,000 pregnancies in the United States. However, the incidence can vary significantly based on ethnicity and geographic location. African American women are disproportionately affected, and higher rates are also observed in women carrying multiple babies, those over 30, and those with pre-existing high blood pressure or other cardiovascular risk factors. The symptoms of PPCM can mimic those of a normal pregnancy, making early diagnosis challenging. Common signs include shortness of breath, especially with exertion or when lying down, persistent fatigue, swelling in the ankles, legs, and feet, rapid or irregular heartbeat, chest pain, and persistent cough. It's crucial to remember that these symptoms, especially when new or worsening, should be promptly reported to a healthcare professional. Diagnosing PPCM involves a combination of physical examination, patient history, and diagnostic tests. An echocardiogram, an ultrasound of the heart, is the primary tool used to assess the size and function of the heart chambers. Other tests may include an electrocardiogram (ECG) to check heart rhythm, blood tests to measure cardiac biomarkers, and possibly an MRI of the heart to provide more detailed images and rule out other causes. While not strictly classified into distinct types, PPCM can be categorized based on the severity of the heart failure symptoms, using the New York Heart Association INAH functional classification. This classification ranges from Class I, with no limitations of physical activity, to Class V, with symptoms occurring even at rest. The severity of the left ventricular dysfunction, as measured by the ejection fraction, is also a key factor in assessing the condition. Treatment for PPCM focuses on managing heart failure and supporting the heart's recovery. This often involves medications like diuretics to reduce fluid buildup, ACE inhibitors or ARBs to lower blood pressure and improve heart function, although these are typically avoided during pregnancy. Beta blockers to slow the heart rate and reduce stress, and digoxin to strengthen heart contractions. In severe cases, an implantable cardioverter, defibrillator ICD, or even a heart transplant may be necessary. Close monitoring and lifestyle modifications, such as a low-sodium diet and fluid restriction, are also vital. Because the exact causes are not fully understood, primary prevention of PPCM is difficult. However, managing modifiable risk factors like high blood pressure, obesity, and smoking before and during pregnancy may help reduce the risk. Early and frequent prenatal care is essential to monitor for any warning signs and ensure prompt intervention. The prognosis for PPCM varies widely. Some women experience a full recovery of heart function, while others may have persistent heart failure. The earlier the diagnosis and treatment, the better the chances of recovery. Recent research is focusing on identifying biomarkers that can predict recovery and developing targeted therapies to address the underlying causes of the condition. One promising area of research involves investigating the role of prolactin and its cleaved form, a protein fragment that may contribute to heart damage in PPCM. Ongoing clinical trials are exploring potential treatments aimed at neutralizing this protein, offering hope for improved outcomes in the future.